Good afternoon and welcome everyone to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Laurie Heavey and I'm a Georgia HFMA Education Committee volunteer. We're at the halfway point of our Wednesday webinar series, and thank you all for joining us each Wednesday. I have promised we have more webinars and other virtual activities to come as we continue on through this interesting time. If this is your first time joining us, I encourage you to check the Georgia HFMA website to hear recordings from our previous sessions. We've had tons of great experts sharing their expertise, of course, topics related to the COVID-19 pandemic, but best practices in other parts of revenue cycle as well. So I encourage you to do that. For today's session, we're pleased to have Sarah Mendiola. She's Senior Vice President of Denials Management for Revint, who will share best practices in denials management to optimize reimbursement. Before we get started though, let me just cover a couple of quick housekeeping items. All of the phone lines will be on mute to avoid interruptions during the broadcast. Please submit your questions using the question box at any time, and I'll coordinate with Sarah for her answers at the end of the presentation. In just a minute, I will also post a link so that you can download the presentation. I'll post that in the chat box. And this link is going to take you to the Georgia HFMA website, and you'll see a tab entitled, you'll see a tab called Documents, and then underneath that, in case you missed it, and we'll post the presentation there, as well as a recording of today's session. Everyone on today's call is eligible to receive continuing education credits to participate. Be on the lookout for this form. It'll come in your email. I'll send it by the end of the week to you, and you'll be able to self-submit on the HFMA website under the Membership Info tab. So again, for today's presentation, it's my pleasure to welcome Sarah Mendiola. As I mentioned, Sarah is the Senior Vice President of Denials Management for Revint, focusing on claims denials, appeals by CMS contractors, and commercial insurers. Sarah's background is very impressive. She's a licensed nurse, a certified professional coder, and a lawyer. Sarah also served on active duty in the U.S. Army for 6 years as a nurse. So Sarah, thank you so much for your service to our country. Today, Sarah represents clients at administrative law judge hearings and has obtained favorable results for claims denials for zone program integrity contractor audits. Sarah, we are ready to begin. I'll turn it over to you.
Great. Thank you so much for having me. Thank you guys for being here. I really appreciate it. Just so you know, today is the first sunny day in Baltimore, Maryland, and I feel like everybody is mowing their lawn right now. So I apologize if there's background noise or if for some reason I start sneezing uncontrollably. Just bear with me. So just as a quick disclaimer, I am an attorney. I'm not your attorney, although we could potentially change that if you would like after this. So just bear in mind that everything that we're talking about today, nothing should be construed as legal advice. We're really just going to talk about best practices and hopefully give you some ideas when you're looking at your own internal denials management team, or even deciding if, it's potentially time to outsource your denials to a vendor. This is a really interesting time, especially, hospitals are going through furloughs. Resources are really being extended and kind of pushed to the breaking point in a lot of areas. We're seeing a lot of case managers who typically assist in the denial space being moved to the front lines and really having to assist with patient care as well. So now is a good time just to maybe even take a quick look at your resources and see where things are. We do understand that authorization is a little lax now. We're hearing plans say, you don't have to do concurrent review. We're not going to hold you to all of these administrative processes that we've held you to before, and we're going to go ahead and pay the claims up front. But at the same time, I think that will put us at risk on the back end for potentially seeing some post-pay audits in the future and medical necessity denials as well. So I know there's a lot of concerns and a lot of thoughts in everybody's head right now, but in the denial space, I think those are definitely things that we need to be thinking about right now. So we're going to talk today about, like I said, really looking at the process of what an internal denials management team should look like, potentially when would be a good time to outsource things, how to identify these denials, making sure there's a good, strong process in place. We're really maximizing our appeal quality, making sure we're putting our strongest arguments out there every time and writing the best appeals that we can possibly write. And one of the most important things is tracking those results. I'm gonna show a couple of different examples of different types of reporting that could potentially be useful for various areas. Definitely for prevention, we want to try to stop these denials from even occurring up front, but also some of the data that can be produced from the denials and appeals process can also assist with contract negotiations. So we'll run through a couple of those scenarios and how that data could be helpful during those negotiations in the future, a little bit later as well. Whenever you see one of these little keys on a slide, that means we're addressing one of these 5 keys that we're going to be talking about today. So the first thing we want to do, of course, is take a look at our resources. What do we have available to us internally? How are we able to combat these denials in an effective, efficient way, and to be as productive as we can with getting as many overturns as we possibly can? So this could include, having an internal team of your own, outsourcing, or potentially having some kind of hybrid of the two. Maybe there are certain denials that you handle in-house. There are others that, you feel are a little more difficult, a little more time consuming, or maybe the volume is just exponential, really difficult to manage. And those are the accounts that you have decided that you're going to outsource. So we really want to take a look at the volume, the types of denials, and what are the expectations that we have that we want these claims to be managed? What is the time frame? What is the expectation for volume completion? And how can we move these through the appeals process as quickly as possible to hopefully, in the end, get the overturn? Without giving away the secret sauce, I just wanted to talk a little bit about what our process looks like in our denial service line. I think this is a good blueprint or an outline for you to kind of take a look at and compare to what your team is doing internally to see if it's something similar or if there are any areas for potential improvement. So one of the things that I will note here, you see it's broken down into several different steps. Within our process, we have various levels of expertise, and those different departments handle different parts of the appeal process or the appeal writing. So as you'll see, our initial reviews are typically conducted by someone who is not a clinician. They're the one that determines what the denial is. The clinician will write the appeal, but our clinicians do not follow up on the appeal. There are administrative staff that does that. So part of our volume expectation, again, is based on how we manage each department and what we expect from their part of the process. I'm not going to read this to you in depth, but just to kind of go through and at a high level explain what we do. The first thing we do is pull all the documentation into our system. This is very important as well. As we talked about tracking and trending and doing reporting, it helps us to be able to easily identify trends to report back to providers. We do have a proprietary software system. I'm going to show you some example of those reports at the very end. But again, if there is some way that you can compile all of the information in one centralized place to be able to track it much easier on the back end, then I think you'll get better results from that as well. One of the first things that we do is time frame the appeal. Everything is driven by when that appeal is due to that plan, so we make sure that we get it out timely. Once the appeal is time framed, we do a root cause analysis. I'm going to talk on a couple slides here too about actually determining what a denial is. For our purposes, when we talk about denials and denials management, we're really talking about any variance on the remit. So it could potentially be an underpayment, it could be a lack of authorization issue, or we're also talking about those utilization denials where the inpatient level of care has been denied or a claim is denied for medical necessity, and even the post-pay denials, DRG downcodes, or other post-pay audits that plans are doing. So we use the term denial very broadly, but it's very important to understand how your organization is going to categorize that. And when you do the root cause analysis, make sure that you have very explicit categories that you can put those denials into various buckets for later reporting as well. So we do a root cause analysis. An attorney or a senior analyst reviews all of the documents, figures out what really is the heart of the issue, what really is the problem. If we need to make a call to the plan, we will do so. We'll also review any state laws, contracts, payer policies that could be applicable to that specific denial. Once that's determined, if there's a clinical review that's necessary, the documentation is then forwarded to our clinical team. We always review the appeals before they go out the door to make sure they're complete with all of the best arguments that can possibly be added. And step 5 and 6, the follow-up, I think this is something that when we look at it, we think it's very basic. Okay, you're following up with a plan. Anyone who has made calls to insurers know that this is such a time-consuming process. So it's not like a crock pot. You just set it and forget it. You send in the appeal, you throw your hands up, we'll see what happens. Once you send in the appeal, you still have to confirm that it's received, confirm that it's in the appropriate department, confirm that it's being reviewed. And then even when you get an overturn of the denial, that's not the end of the story either. We have to follow up for payment and make sure that the claim is not underpaid and everything has been paid appropriately per the contract. If the claim remains denied following internal levels, you always want to look at additional avenues for pursuit. If a claim is viable and you feel adamant that the denial is erroneous, that's something that you want to push up as high as you can possibly go. We don't want to set a precedent that, we're just going to take these denials and kind of roll over and, okay, yeah, maybe you're right. We'll just suck this one up and write it off. If it's something that you feel very strongly about, there are always additional avenues for pursuit. We just have to really determine what they are based on the contract and whatever applicable laws for that plan. So we're still assessing our resources. I talked quite a bit on that slide, sorry about that. But you also want to take a look at your staffing and the types of denials that you're seeing. We want to make sure that there are members on this denials team that are able to manage the full gambit of denials that we see. So traditionally that would be someone from HIM who would be looking more at the coding or the DRG downcode denials. Someone from PFS who's assisting with the administrative or technical issues, and our case management or utilization team as well. The tip here, as we noted, if it's possible, it's very important to try to allocate staff internally specifically for appeals if you have the volume that warrants it. We'll also talk a little bit about ensuring that our appeals quality is as good as it can possibly be. And sometimes, we're all stretched kind of thin as it is, and just, putting additional duties on top of someone, some things fall by the wayside. So we want to ensure that we have a group that is trained up, well-versed, and can manage this volume of denials. We also want to make sure that everybody is working together. This is a little bit fuzzy, but I think this is a good example of one of those things that would typically be managed by our HIM or our coding team. But now, as we're seeing with DRG downcodes especially, these are now accounts that need a clinical review. So not just DRG downcodes, but there are various denials where it's not just a clinical, it's not just a coding, it's not just a technical denial. We now need to make sure that we're working as a team and incorporating all of those elements or all of those pieces into the best appeal that we possibly can. So ensuring that we have that cross-departmental review, that we have this team that is able to manage all of these different sorts of denials that we're seeing. As you see here, the denial says that the clinical evidence does not support this diagnosis code. In the past, when we would see these denials, it was typically because there was a lack of documentation, or maybe the coding rules didn't support the code, but it is very specific here that there was insufficient clinical evidence, which is all listed out in the previous sentences. And then we also see clinical journal articles being cited in support of why the diagnosis code is removed. So ensuring that we have the resources and the trained staff that is able to manage these sorts of denials, that can be a hybrid, or ensuring that we're able to direct them to the appropriate staff members. So that also brings us to training. It's really about being able to recognize what the denial issue is, what the root cause of the problem is. And again, so that way we can get it to the person that is able to fight it most effectively. We want to make sure, and the tip here also says, assigning a point person for each payer is definitely a great idea. I'm being recorded, I have to remember that. I sometimes make colorful comments about insurers, but I'll keep it to a minimum. So it can be good to have a liaison or a point person that communicates almost exclusively with the provider rep or with the representatives at an insurer. It helps to create a relationship, which in turn can help to create additional accountability that may not have existed before. And that way it may be a little easier to move appeals through the process or get claims sent back or get things reviewed as appropriate. One of the things that is also very important is training for writing appeals. You know, I think we have the tendency to think it's pretty easy. You're just writing a narrative. You're really just explaining what happened. That is not at all the case. We want to make sure that in our appeals, we are being as persuasive as we can possibly be. I was once told by someone who reviewed appeals for an insurer that they have 4 to 7 minutes to review the appeal, make a decision, and move the case on. So when we're writing our appeals, we need to make sure that we're being concise, we're being very clear, and we're being as persuasive as we can possibly be. As I mentioned before, volume is going to be one of the most important factors that you're looking at when determining how you are going to manage an internal denials management team or what your process is going to look at. And unfortunately, this is one of the things that we find that providers have quite a bit of difficulty tracking. I think it is a lot of times related to how the remits come over, how the claim is written off, and what the facility is actually defining as a denial and how that is being managed. But it's very important to do an internal assessment and take a look at, you know, weekly, what are we seeing? Monthly, what are we seeing? Quarterly, is there a specific insurer? Is it managed care, or are we seeing more commercial, or are we seeing more governmental denials? What are we seeing so that we can hone in on that volume first and try to chip away at that biggest volume first? If there is too much volume, appeals quality can really suffer. If you have a lot of denials that you're just unable to get to, either the appeals quality will suffer, or we have seen providers just write off quite a bit of the inventory because there's just a feeling that they're not going to be able to get to it all and be able to appeal it. So again, volume is very important when looking at your team and if your team is able to manage the denials that you're currently seeing. Quality goes hand in hand, I think, to me, again, with training, with the volume, making sure that we're really taking the time. We're not just throwing someone into a denials position and saying, here, write some appeals. You're familiar with Cigna or UHC or Aetna. We're going to give you this group of appeals to write. It really is an art to be able to write an appeal and to convince someone that the decision that they originally made was the incorrect decision. If there are issues with this, any gaps will become apparent as you're going through this assessment. Again, looking at your team, looking at your process, looking at your volumes. What types of denials are you seeing? What are you able to manage internally versus what might you need just a little bit more help with? So at that point, it might be a good idea to consider outsourcing again if you have resources to address some things but not others, or maybe it's just too much of an undertaking and it's something that you just want to outsource for a while and then work on creating your own internal denials management team. For hybrid sorts of cases, things that we recommend typically for outsourcing, if you feel comfortable with the staff that you have, you feel confident that you're able to manage most of your denials, there are still some areas potentially where outsourcing could be beneficial. So it's something to consider. If payers have one level of appeal only, we definitely want to put our best, most strongest argument out there at the outset. High dollar cases, something that is complex, that has a contractual or legal issue to it. There are a lot of denial vendors out there who work with attorneys. We at Revint have legal staff as well. As you heard, I'm an attorney as well as a nurse and a coder. So sometimes those legal issues just need a little different eye, and it may be a good idea to outsource them. This one I think is really important. Accounts that are deemed not viable for appeal by your current appeals staff. Sometimes there is opportunity to just have a second look at something. So this is really important for, let's say, your inpatient claims. You're receiving quite a few lack of medical necessity, lower level of care denials, and initially you just decide, you know, the volume is too high or we're never going to get this overturned. So the decision is made to go ahead and convert it to outpatient on the front end. Instead of sending in the claim as inpatient, you downgrade the claim to outpatient. We have been very successful with reviewing these kinds of accounts on a second look to see if it's something that we may be able to appeal. So it's just something to think about for a second look. I think nurses and clinicians internally are trained superbly, and they're very good at utilizing Milliman and interqual, but sometimes there are regulatory arguments that can be made that they just may not be as well versed in. So second set of eyes doesn't hurt. Also, if appeal rates have been exhausted, like I said in the beginning, if there is a claim that you are just adamant that the denial was erroneous, it's just completely ridiculous, you're not sure what to do with it, a lot of times those accounts can take a lot of resources to be able to fight outside of the internal appeals process. So that may be something that you would like to consider outsourcing as well. So we talked about ensuring that we're properly identifying denials so that way we can properly route them to the teams that we want to work on them. Figuring out the root cause is very important. One of the things that needs to be evaluated is who is going to be the one to appeal these various kinds of denials. So will our administrative denials stay with our PFS and our billing teams? Will our clinical denials be with case management, coding and billing, HIM? It may be a good idea to consolidate a team of 1 to 2 people from each of those departments that can each assist in that process of the appeal writing. Let's say, for example, you have a lack of auth denial. Of course, we are going to want administrative input on the front end. What happened? Why did we not get authorization? What was the issue there? A lot of plans now are moving to one level of appeal, or else when you overcome that administrative hurdle, now your next denial is going to be medical necessity. So best practice would dictate, even if you have a lack of auth denial, you make that administrative denial and get over that hurdle. And then let's also incorporate our clinical denial, our clinical information as well. So that way we're heading this plan off from even giving us the denial for medical necessity. Throw in the kitchen sink, especially if you only have one level of appeal. You want to make sure that your appeal is as strong as it can possibly be. Not only are we making an argument for payment, but you got to think about it from a lawyer perspective too. You know, we want to lay the foundation. If this is something that we know should have been paid, we want to make sure we put all of our arguments in there. So that way, if we have to escalate it, we can explain that we already included all of this information to the plan. It just was not appropriately considered the way it should have been. When we're reviewing our denials again, I can't stress this enough, is making sure that we understand what the root cause of the denial is. Very often, denials on remits can be very ambiguous. Number one, I think, is one of the most common ones that we see that winds up being written off. The remit indicates that the charges are denied as non-covered, and I think there's a perception that that means it is a non-covered service, aka a benefit exclusion, which is not always the case. That denial can mean it is not considered medically necessary due to a policy, a whole host of various things. So not taking our denials at face value, making sure we have someone that is able to investigate these ambiguous denials so that we can adequately address them. The second one is also a pretty common one we see. It indicates that the charges are denied because it exceeds the fee schedule. Typically, we look at this and it's a contractual adjustment. Okay, we get it. Sometimes that's not the case as well. Or it could be a contractual adjustment, but it's an incorrect contractual adjustment. Maybe it's an underpayment and you're due additional payment for high-cost implants or high-cost drugs or something else that is written into your contract that the plan did not take into consideration when they paid this claim. We also see this reason for lack of auth issues pretty frequently. If one level of care is authorized and another one is billed, this denial will come across as well. The problem is that the indicators are not always universal from plan to plan to plan, so we need to ensure that we understand what the denial even means so that we can adequately fight it. So I talked a little bit about this in slide 4 just to kind of explain what our workflow looks like. I think this is illustrated really well right here when we talk about the life of an appeal. Even in your own internal process, we want to make sure that each one of these steps is really being hit and appropriately manned, staffed, and reviewed. So we get the denial in, again, that root cause analysis, ensuring that we understand what the denial is, making sure that we're having the adequate trained professional review it to draft the appeal, sending the appeal to the appropriate place, ensuring that it's received, ensuring that it's being reviewed, and even if we get an overturn, following up for that payment and moving that case all the way through to resolution. So in refining our process, there are definitely some tools that we can provide our team to ensure that they're able to work as efficiently and effectively as they can. One of the things that we often advocate to our clients is a payer matrix. This document is what I call organizational knowledge brought to life in a document. So this should be a living document, Excel spreadsheet, whatever format works best for you, where anyone who is working in appeals can access this document, very quickly understand what the appeal rights are, where the appeal needs to be sent, what the rebuild timeframes are, any information that would be needed by the denials management team. And this is just an example of a sample payer matrix. Most of this information is correct, but I would not, like I said before, none of this is legal advice. I wouldn't take this as gospel truth and put this in your current spreadsheet, but most of this is accurate. This is really just to illustrate what a payer matrix should look like. So here on the left-hand side, we list the payers and whether we're contracted or not. This is very important as well because your contract may have different time frames than the provider manual or the website has. If for some reason an appeal form or other documentation needs to be submitted with the appeal, that's also pretty important to include on the matrix as well. There are certain payers now that are kicking back appeals if the appeal form is not submitted. And unfortunately, if you are past time frame, once you receive that notice, they will not accept that appeal untimely. They basically say you should have known you needed the form and submitted it. It's also important to understand from a contracting perspective who we are contracted with, again, because our rights may be very different. So for example, here I have United Healthcare. We are contracted with their commercial product. We are not contracted with their Medicare product. This is very important because the time frame is very different for appeals for a non-contracted Medicare Advantage plan. I can't tell you how many times I've seen denials based on the assumption that because we are contracted with United Healthcare, that means we're contracted with all product lines. That's not necessarily the case. So again, it's very important that we communicate with our managed care team and make sure that we have any information that may differ from what we see, on the website or provider manual or any other documents. So this right here for me is the meatiest part of the presentation, or the chocolatey center, I guess, depending on what your current craving is. Maximizing appeal quality, we always want to make sure, like I said, we're putting our best foot forward. Some of you, I believe, were at the Southeast Summit where Gail Robinson and I talked about keep calm and how to appeal like a lawyer. There are various principles that we apply when we're doing our appeal writing, again, to make sure that we're clear, concise, and we're able to get our point across very quickly and easily. These include, of course, the facts of the individual case, any relevant contract terms and provider manual, relevant law, and legal theories. I'm going to go through each one of these in more detail as well. So the facts of your individual case, what happened here? If it is a lack of auth issue, why didn't we obtain auth? What do our account notes say? Is there something in there that's strong enough that we can cut and paste a snippet into our appeal and explain what Bob from Cigna actually told us when we called? Or shows that we did submit a request for authorization. It was supposed to be provided within a certain amount of time based on our contractor provider manual, and it was not. So we always want to make sure that we are focusing on the facts of that individual case and things that help us. Down here at the very bottom, it says, if a procedure was not complied with, oh, my bad, here we go. If a procedure was not complied with, explain the reason for the non-compliance. So we talked a little bit during the Southeast Summit about what attorneys use an acronym PLEA, which is persistence, logic, exculpation, and advocacy. So E and A are the most important ones really to us. We want to make sure that we are not conceding. We are not telling the plan, oh, we're sorry we did something wrong. Please forgive us or please allow us an exception. Don't ask for an exception, don't concede. Let's focus on what we did right. So even if a procedure was not complied with, when we're explaining the reason for the non-compliance, we're focusing on the positives. We're focusing on what we did right in this scenario and perhaps what the plan did wrong, so that again, we can make the strongest, most persuasive argument in our appeal that we possibly can. Your contract terms and provider manual are always going to guide the relationship and the expectation between you and the plan. I repeat, between you and the plan. So if the plan is not adhering to a requirement in the contract and they are violating those terms, that is something we really want to point out at the outset of our appeal. Strongest language we possibly can. Again, cut and paste or a little snippet of the actual contract terms that the insurer is violating can be extremely compelling. Authorization and notification issues, like I said a couple slides before, even if it's an administrative or technical kind of denial, we still want to make sure that we include our clinical argument, but the focus of that appeal should really be on the authorization or notification issue. So if there are contract terms, provider manual documentation, anything that we can really utilize, again, to show that we did everything we could possibly have done at the outset, the plan is the one that erred, or the plan didn't follow the contractual or manual requirements, then we want to do that and highlight that at the outset. Federal and state laws. I'm not going to read each one of these, of course, but there are several regulations that are very helpful for providers when it comes to coordination of benefits issues, medical necessity kinds of issues with newborns and mothers, breast cancer and reconstruction, EMTALA, various types of statutory references that could be really helpful in your appeals. One thing that we like to try to argue is for interest on claim payments. If we can make an argument that a clean claim was submitted, maybe it was partially denied, or it was clean from the very beginning and the plan erred, we will always try to put in an argument for interest. Sometimes it's compelling based on the plan type, sometimes it's not, but I always say let the plan tell you that you're wrong. Especially as a non-legal professional, you are allowed to use any state, federal laws and statutes to your benefit. If you think it's something that is compelling for that particular account, I would throw it in there and let them tell you that you're wrong. And the reason I say that also is because it can be kind of confusing as to what is the controlling law for a particular kind of plan. Here, this is a very simplified kind of version. If it's a fully insured plan, state law is going to be the guiding law. If it's a self-funded ERISA plan, federal law is going to be binding. Medicare and Medicare Advantage, we know federal law is going to be the controlling law. And if it's a Medicaid or a Medicaid MCO, Georgia or whatever state you're in, law is the one that is going to be controlling. But I say throw it in, let them tell you that you're incorrect. Some helpful legal theories that could be helpful for your appeal writing as well. These are not arguments that are necessarily going to stand alone and sway the day, but these are great supplemental arguments. So if you're able to make a contractual or provider manual or great administrative argument at the outset, you can throw this in as an aside. And these legal theories are course of dealing. So basically, this has never been a problem with you before. We have several claims that you've paid with the same instance. It doesn't make any sense that now you're denying the same exact scenario. Misrepresentation, the plan told you something that later it was determined not to be true. An example of this is a patient had active benefits on a particular date. Come to find out retrospectively, the patient was not enrolled or their benefits were in fact not active and it was a COB issue. Detrimental reliance is exactly what it says. You as the provider relied to your detriment on information that the plan gave you. Had they not given you that information, you would not have performed the service. So again, these are additional arguments that can be helpful, not necessarily the thing that you want to highlight at the outset of your appeal, but definitely something you can utilize as an aside to strengthen the facts of your case. So this is just, we're going to go through a couple examples here. It's unfortunate that you guys aren't in front of me and I can't call on people. That does make me a little bit sad. But our problem here is this hospital rendered medically necessary services to our Jane Doe from November 15th to 16th. She was admitted through the ED after arriving by ambulance. A claim is timely submitted on December 1st. On February 28th, the plan denied the claim for lack of authorization and notification. So here we just want to walk through those 4 different things and make sure we are including everything in our appeal that could potentially assist us with getting this denial overturned. So the facts: patient came in through ED. Was this an emergent admission? Was the patient comatose? Were you unable to obtain the insurance information for whatever reason? If it was impossible to obtain authorization based on the patient's presentation, that is something that we want to include at the outset. That it was a clear impossibility, the provider should not be penalized for providing appropriate emergent care to this patient. If there are any contract terms or provider manual terminology that you can utilize to put into your appeal, any relevant laws, EMTALA, and as we know, ED services do not require authorization up to the point of stabilization. This is an argument that can be utilized, of course, depending on what the documentation in the medical record says. It can be a very successful argument. I will say for Medicare Advantage in the CFR, there is specific regulatory language that says this. So if you have a lack of authorization out of network denial, and you can make an argument that the patient was not stabilized until the point of discharge or transfer, that can sometimes be very compelling and assist in getting an overturn. And then any helpful legal theories or course of dealing or anything that anything else you could think of as an aside in the particular instance, depending on the facts of the case. Since this was a lack of authorization denial, I thought this might be a good place to throw this in here, since we're talking about arguments that you could potentially utilize in your appeal. These are actual contract terms requiring that the plan review for medical necessity, regardless of whether the provider obtained authorization, followed all administrative procedures, those kinds of things. I wanted to throw this in here. I'm not sure how many managed care contracting folks we have on the line, but I think we traditionally, when we come to the table with these insurance companies, we're really focused on rates. We want to make sure that we can get the best rates that we possibly can. Even in looking at contracts as a professional in this industry, we see tons of rate amendments, very few base changes in the actual language or terms in the base contract. So this may be an area for you to take a look at to assist in potentially preventing some of these denials from happening, or even, giving you additional tools that if the denial still takes place, we can argue that the contractual agreement wasn't followed. Sometimes you got to give a little to get a little. So you may take a hit on some of these rates, but then at the same time, if we have terms that are 5 and 10 years old and just open you up to retrospective reviews and various other types of administrative denials, we're really not protecting ourselves to maintain those excellent rates that we have. So, sometimes we got to give a little to get a little, basically. So this second problem here is more of a clinical issue. As you can see, the plan denied, saying that the patient's admission did not meet Milliman. I'm sure no one has ever seen a denial letter like this before. This is something completely new to everyone. This is the most frequent kind of denial that we see. Plans saying that the patient didn't need to be admitted as an inpatient at all, or could have been admitted to a lower level of care, such as observation. In this particular case, they're saying you didn't need a quote unquote full hospital admission, which tells me they're saying the level of care was inappropriate and that they based the denial on Milliman. So when we're writing our appeal, this may look like something that is solely clinical. all we're going to talk about is medical necessity, but there's also an administrative component here. The denial very heavily relied on Milliman care guidelines. So my very first question would be, is that appropriate? Per our contract, per our provider manual, are they permitted to deny the claim based solely on Milliman care guidelines? If so, is there any argument that we can make that Milliman actually was met? It's interesting, Milliman and Interqual are supposed to help, make admission decisions a little bit more objective, but there is still quite a bit of subjectivity to both of those care guidelines. So perhaps the Milliman guidance that the plan is citing was based on the patient at the time of admission, but throughout the admission, there was a different diagnosis made at the end. So the patient presented with seizures or stroke, but then at the end of the day, we found out the patient had a tumor. So is there a different Milliman criteria that we can provide and say was actually in fact met? That kind of lends to B as well. Authorization was denied, but the plan only considered the admission documentation, not the entire record. So our argument is, yeah, you may have denied it on the outset based on the ED documentation you received, but look at the level of care, the acuity of services, all of the different things that we had to provide to this patient while he was admitted. Clearly it was appropriate. I briefly touched on contract terms and provider manual in the setting of the utilization of MCG as the reason for the denial. The relevant law, was this an emergent admission that we could possibly tie in EMTALA? And again, talk about the stabilization services. And then for helpful legal theories here, I did mention as well, even if Milliman was not met, there are disclaimers to the care guidelines as well. And they very clearly note that the guidelines are meant to be screening tools and they are not a replacement for clinical judgment. So even if the plan is saying Milliman wasn't met, if it is not written in your contract that medical necessity decisions are made based on this care guideline, I would argue that it doesn't matter. Our physicians clearly documented why admission was appropriate. Here's what the documentation says. And then finally, was it actually a physician that denied this claim? And is it required to be a physician? What does your contractual agreement say in regards to clinical determinations? A couple years ago, there was all that hubbub with Aetna, I think in California, where there were just rubber stamps being put on to these denial letters. Is that what's happening here? Does the clinician look at the facts of this case and very clearly say, no, that's incorrect, the patient had to be admitted? So what kind of argument can we make? So finally, I'm speeding up a little bit here. I see I only have 17 minutes left. The problem with attorneys is we really like to talk. So I could just talk and talk forever. But I really wanted to get to this about tracking results. We talked about assessing the team that you have on that's doing the denials work, assessing the volume, looking at the types of denials that you're seeing, making sure that we have a good process in place, making sure that we have a good work product in place. But we want to take a look at how are we doing with these appeals? What is our overturn rate? Where are our problem areas? What are we just not able to get overturned? And there's multiple reasons for this, as I said at the outset. Prevention purposes, we want to try to prevent these denials moving forward the very best that we possibly can. Payer accountability. Do we consistently see that the payer is taking advantage of a particular type of denial or type of service that they're egregiously denying over and over and over again? And we can bring that to their attention. And also utilize it for contract negotiations at a later date. And internal process changes. Do we see that there are specific areas of breakdown that maybe we do need to talk to our registration and authorization team because we're not getting the authorizations the way that we should? Or maybe we have a certain physician that no matter how much we talk to him, no matter how much we train him, our physician, champion, and advisor has tried, and we just cannot get him to admit his patients to observation. That the data can be very compelling to take back to these departments or these practitioners to be able to actually give them numbers and show them the financial impact on these decisions that they're making. So we're going to look at a couple different ways to track the denials that you're seeing, track the resolution by payer, by service type, and then see what decisions can be made from there. We're going to look at some outpatient reporting examples first. And we did these in a couple of different ways. As I mentioned in the beginning, I think it can be very difficult for providers to really get a good grasp or a good handle on the denials that they're seeing unless they have a good software that's in place. So we wanted to show some manual ways that you could potentially track this as well, through Excel spreadsheets or various other types of ways to make sure that the team is able to accurately capture all of the data for use later. So hopefully, yeah, I think this one's nice and big. So this example right here is a payer report card. This is one payer with the top denied outpatient services from this payer. So the first thing that I see here is, for the lack of authorization, there's quite a bit of volume for this particular drug. And then when we look at our overturn cases, we have a very high overturn rate. Now, mind you, the overturn percentages are based on cases that have been brought to full resolution. So if accounts are open, they're not factored into this overturn percentage. However, I think that's still pretty compelling. You have a lack of auth denial for this drug. Again, look at this volume, 74 accounts, and the vast majority of these are being overturned. So this is information that we would want to take back to the payer and say, hey, what are you doing incorrectly? Are you not paying attention to our authorizations? Do we have contractual language that you have to review regardless of an authorization or not? And if that's the case, what can we do to prevent this denial from even occurring? Perhaps, a medical record submission at the time of claim submission, so that way the medical necessity is reviewed up front and you don't have to continue to jump through hurdles, get the claim denial, file the appeal, follow up for overturn, spend all that time and man hours on the back end, just trying to get that payment that should have been made for medically necessary services on the front end. So again, this is just one way to look at a payer report card. Like I said, this is one payer, top denied, and you could really drill down into each one of these accounts to figure out what the actual issue was. The second example, this one's a little fuzzier, sorry about that. This is a payer report card for multiple payers. So as you see on the left-hand side here, we have payer A, B, C. This is all for the same denied service. So what stands out to me immediately is that we have payer A denying this service for experimental investigational when none of the other plans are denying it for that reason. So did this payer come up with a new policy? Was there something released in a bulletin or a memorandum that we did not receive or were not aware of? And then the next thing I would think is, are these other plans going to follow suit? So if a new policy was released, or maybe CMS released some additional guidance, we know that insurers like to grab a hold of CMS guidance sometimes because it makes it a little easier for them to deny claims, and they have a good foundation to use by saying that, well, CMS released it. It's good, accurate information. They did a lot of testing and research, and the LCD has a lot of good journal articles and periodicals cited, so we can deny it for that reason as well. So I would be concerned that other payers may follow suit. And is this something that we need to drill down into a little bit further to see, did the diagnosis reason change? Is there additional documentation that we're going to need to harden our record to make sure that we're supporting that the services were clinically appropriate? So this last one here, this is one of my favorite outpatient reports. This is a lack of authorization drill down. So lack of authorization, as you see here, can mean a lot of different things. I think our first inclination is to say, well, we didn't get it. We obviously didn't get the authorization, and that's why it was denied. The vast majority of the time we have found that that is not necessarily the case. So it's really important, but before we go blaming our folks that are supposed to get these authorizations, what's happening in these cases? That was there an authorization obtained that wasn't honored? Was it obtained for an inappropriate service? Or did we not get it at all? So that way we can go back and do some training and coaching and counseling with that team as to how they should obtain those authorizations moving forward. So right here, you could see the highest volume for this MRI is that an authorization was obtained, but it was for a less complex procedure than the one that was performed. I think that is actually very interesting. And, I would question, where are these patients coming from? Is this coming from one particular physician's office? Are they consistently requesting authorization for something else? And maybe the facility has a protocol based on diagnosis to do a different test, and the test is just being performed. So that's definitely something I would drill down to. The second one here, these epidural injections, failure to authorize. I think that goes to our more traditional authorization was not sought, authorization was not obtained. This is concerning as well because the success rate here is very low, so only a 56% overturn rate. So the question would be, who is responsible for obtaining that authorization? And going back to them and really trying to understand why it wasn't obtained, and then why are we not able to get these overturned? If no authorization was sought and the authorization is clearly required by the plan, it can be very difficult to get those denials overturned unless you have good, strong contractual language. In situations where there was a misquote or we got authorization for something else, or maybe there was an add-on, those can be a little easier to get overturned, but not seeking authorization at all, they can be pretty difficult to fight. So just some inpatient reporting examples. Typically, the highest volume of inpatient denials that we see are for level of care. As I mentioned before, either the plan saying the service wasn't medically necessary at the hospital at all, or the patient could have been treated in OBS or treated and streeted. Take them to the ED, fix them up, and then send them out the door. So the reporting here can be very helpful to determine how those claims should be billed on the front end. As I had mentioned before, it can help to have a second set of eyes take a look at those claims that we're thinking about downcoding, or we may have really good hard data analytics that show we need to downcode these claims at the time of billing because we're just never going to get paid at the inpatient level of care for this service. So this is an example of some reporting for inpatient by DRG. So the indicator here is the DRG drill down and what the title of the DRG is. And again, same thing. Here we're looking at what is our highest incidence and lower overturn rate, and what can we do process-wise to potentially change that and either get the money in a little bit quicker, or are we wasting our time and spinning wheels appealing these things that are just never going to pay? So the one that stands out to me is appendectomies. Surprising, 16% overturn rate overall. And you can see here for 1-day stays, it's a 5% overturn rate. For 2-day stays, it's a 32% overturn rate. Not surprising. Lap appies are typically surgeries that are done on an outpatient basis. If the patient is in longer, then typically it's a septic patient or had to be converted to open. So that makes sense as to why they were overturned at a higher level. So this is good data to, again, either discuss with your physicians, why are we still admitting these patients as inpatient? Can we institute some sort of protocol for our appendectomy patients regarding an order set? Or if they are continuing to be admitted at the inpatient level, is this a particular type of DRG or particular type of account that we want to just convert to outpatient and bill it that way from the outset? Additionally, if you're seeing 1- and 2-day stays being denied across the board by a specific insurer, you can think about various ways to attack that in contracting. Perhaps a discussion about a short stay rate for specific DRGs could be something that could be beneficial to you as well. Man, I only have 6 minutes left. I'm gonna get there, guys. So I talked a little bit in the beginning about software and the reason that we import the accounts into our specific system. I am not a financial person, so the dollars are not as impactful just for me, although I know they are for many of you. But the visuals, I think, are very helpful. Just to see at a glance where all of the accounts are, what the current status is. So this particular report right here, again, just an example of how our organization reports out. This is all of the inventory for one specific provider, and then we'll drill down to it a little bit more. So the next report shows the top denied DRGs, very similar to the Excel spreadsheet that we were looking at. What those denied DRGs are, what the volume of those accounts are. You can see here which ones are 1-day stays, 2-day stays, 3 days. And then the way that this is set up, it also allows you to drill down further into that DRG type to see where those denials are happening. So this is one of those drill downs just into esophagitis and gastroenteritis. These are typically GI bleeds or unspecified abdominal pains. Patients that are admitted for 1 day, 2 days can be pretty difficult to get those overturned. Pretty often they're pretty benign admissions. But what I wanted to show here was this very clearly indicates that with United Healthcare, these accounts are not being overturned at a very high rate. So 38% and 40%, less than 40% overturned for United Healthcare. So this gives, again, the provider an opportunity to take a look at this population and see what process improvements could be made. Internal tracking, I love these physician report cards. You know, you can tell someone they're doing something wrong, but until you can show them in black and white the numbers and what the impact is, it really doesn't necessarily make as much of a difference as we would hope it would. So one thing that we will often do is, based on the UB, the claim, the physician that's billed on the claim, we could pull down some reporting from that and see, you know, who are your quote unquote top offenders that you really need to do some re-education or some training with. So this could be very helpful for your physician advisors, your champions, even your CDI team, depending on what their initiatives are. And finally, the executive reporting. As we know, our C-suite folks really just want to see 30,000-foot view, give me dollars, tell me how this impacts me, where are we bleeding from, what are our overturn rates, how can we fix it? So making sure that we're able to provide that analysis at that very high level at a glance. And this is just an example of that. This is all accounts and where they are in the process. So that way an executive can very easily see what is currently an appeals status that I could potentially look forward to receiving in revenue. Based on the overturn rate, can we make a prediction of what we have potentially coming down the pipeline in the next few months? And similarly, again, another executive sort of level reporting with the various denial types. So we can see what the problem areas are, where we're seeing our highest overturn rates and lowest overturn rates. Again, for example, here, no auth has a very high overturn rate. I would imagine there's some kind of contractual language that requires medical necessity review. Our DRG down codes have about a 39% overturn rate. So is that something that maybe we need a CDI initiative? Are we upcoding? What exactly is the problem here? Let's drill down and see what those diagnosis codes are. And perhaps we need to develop internal clinical policies to make sure that our documentation is tight and shored up. So that way when that diagnosis is called into question, we're able to make a stronger argument in support of why it was billed. One minute to spare, look at that. So in summary, you know, we really talked about kind of a high level look at how to create your own internal denials management team. I hope I gave you some ideas as to when it might be a good idea to outsource, what kinds of accounts might be appropriate. You know, I think there's often a perception that we have a good handle on our denials, we're appealing everything, but we want to make sure again that we're classifying those denials and we're getting to the root cause to really understand what is a denial that should be pursued versus something that we're kind of just writing off because it looks like it's something that isn't really viable for us to take forward. So I hope I gave everybody some good ideas. I don't know if we have time for questions, but I am available by email as well. I know sometimes folks don't like to ask questions in these forums if they have very specific payer accountability or other kinds of questions. So please feel free to reach out to me at any time. Very accessible, very friendly. Hope that came through.
It very much did, Sarah. Thank you. We do have a couple of questions, and I'm happy to stay on the line here and answer them, or have you answer them as well. Someone had asked for a little bit more specificity in terms of where to download the presentation, so please check the chat box. All of you who are still with us, you'll see the navigation there on the Georgia HFMA website. So Sarah, here's the first, it's kind of asking for your opinion. Historically, we have tried to address denials through contract litigation prior to addressing the clinical merit of a denial. An example is if the contract says the payer only has 90 days to perform post-payment review, but we receive the clinical denial at day 120, we would deny the appeal based on contract term without addressing the clinical denial. Would appreciate your thoughts.
So that's a good question. I think that personally, I would do both just because it sounds like the whole rationale behind the denial is a clinical one. So while you're saying that this is impermissible, you should not have even done this, it's completely inappropriate, I think it only helps to strengthen your argument to show that not only was the way you conducted your review inappropriate, but your rationale was clearly erroneous because the services were in fact medically necessary. So I think taking that dual-pronged approach, if you have the resources, is always a good idea, because we want to make sure, again, that we're laying the foundation to show that not only how you did it was wrong, but your decision was completely wrong as well.
Okay. And then here's the next question or thoughts. What are your thoughts on the influx of vendors entering the market with automated inpatient notification, medical necessity authorization tools? Do you have concerns with the appeal process when hearing providers are looking into this technology?
So that's interesting. I guess it depends on what the tool will do for you and the documentation that the tool provides for you. So if you are able to have a printout or something downloaded into the account that shows what the tool did, from an authorization or eligibility perspective, I think that's a good idea. Medical necessity, I would be a little concerned by that because I think that still needs a clinical eye. So from what I'm imagining is like a millimeter interqual snippet or citation, and then a clinician kind of filling in how the facts of this particular patient's encounter meets that millimeter criteria. Automation scares the crap out of me, just to be completely honest. I think we've seen it with electronic health records, that it has been a great tool to ensure that we're documenting every day, but it has completely shot us in the foot in that there's so much repetition. There's not a whole lot of clear or new thought on every day. So I understand why it's needed, because we need to ensure that we're working as efficiently as possible, but it does make me a little bit wary. So I would want to ensure that whatever your return is something tangible that you're able to utilize should you need to appeal that denial. Okay. I hope I answered your question.
Good deal. Well, thank you. That wraps it up. And I appreciate, Sarah, for you stay on and answer those couple of questions. And for those of you who are still with us, thank you for joining us. Remember that our special Wednesday webinar series runs now through the end of May. So please be sure to join us back here next Wednesday, 1 p.m. The webinar will be Crossing the Clinic Divide, Hospital and Physician Collaboration for Compliant Reimbursement. And be on the lookout for our Wednesday webinar emails to register, or you can go to the Georgia HFMA website and click on the events calendar and register that way. Thank you all again for participating today. And Sarah, thanks so much for sharing your expertise. Sorry we couldn't be there so you could be there with you in person so you could call on us, but appreciate that. Again, Sarah's presentation is already posted on the Georgia HFMA website. We'll have the recording of today's session out there as well, and I will be sending you your CPE form. Thanks again, everybody. Have a great afternoon. Bye-bye.